And without further ado, I'm going to go ahead and introduce Dr. Wade, who is a tenured professor at the University of Cincinnati College of Medicine and Director of Research in the Division of Rehabilitation Medicine at Cincinnati Children's Hospital Medical Center. For the past 20 plus years, she has conducted single-site and multi-center randomized clinical trials of interventions to reduce morbidity following pediatric traumatic brain injury and other neurological conditions, pioneering the development and testing of technology-based interventions to reduce behavioral and family consequences of these conditions. We're so privileged to have you here today, and I'm going to go ahead and mute and just pass the mic. Thanks so much for being here.
So today I'm going to be talking about the Teen Online Problem Solving Program, and I'm really delighted to be talking with you about this because this program is available through the clinics at UCSF. And so I'm hoping that through this presentation, you'll have a better understanding of the program and how you might be able to use it with your with the patients that you work with. So having said that, my slides are not advancing from my laptop. So I might ask Anna to bring up the slides, but let me give it a shot one more time for whatever reason. Oh, here we go. Okay. So let me, but I'm not seeing you anymore. Can you still see me?
Yeah, we can see you.
Perfect. So first of all, I don't have any conflicts to disclose, but as Barbara mentioned, I've been doing this for more than 2 decades. So I've been fortunate to have funding from a lot of different federal organizations. Currently, the implementation project that I'm going to talk a little bit about is funded by the Patient-Centered Outcomes Research Institute. So
Shari, we can't see your slides, however.
Oh, okay. Well, that's a problem. So we're going to start over again. And like I said, if this is not working, then I will have Anna go and bring it up because she has it as well. So you can see my slides now?
Yes, we can see them.
Okay. And I'm going to do from the current slide. So I'm going to talk about the common consequences of acquired brain injuries in children and adolescents. I'm going to talk about a little bit about the evidence base for teen online problem solving, and then talk a little bit more about the specific implementation at your site. So one of the things I've been around for a long time and have collaborated with neuropsychologists for a long time. And one of the things that was very apparent from my early work is many children with traumatic and other acquired brain injuries experience both acute and sometimes chronic lifelong challenges with behavior and executive functioning. But the other thing that was kind of the big aha moment is that most do not receive treatment for those issues. So in my own database, we looked at our cohort of almost 400 children, and we looked at those who had clinically significant elevations on the child behavior checklist. And then among those, the numbers that were receiving behavioral health care. And so you can see that of the 55 to 60%, which the percents aren't on here, about 80% of them weren't receiving any treatment. So there's high rates of unmet need in these populations. So one of the things that I think happens and that makes addressing issues more challenging is we kind of put diagnoses in different buckets. And so a lot of my career I spent working in traumatic brain injury, and there's a decent sized literature in traumatic brain injury. There's a smaller but growing literature for brain tumor survivors. There's a little bit on stroke. There's a little bit on epilepsy. And so we kind of treat these things as separate and very distinct conditions, which they are. But they also have a lot of shared concerns. So as part of our PCORI implementation project, We surveyed about 50 providers, neurologists, physiatrists, psychiatrists, neuropsychologists, nurse practitioners, and asked them to rate the kinds of challenges they saw in the kids in their clinic. And what we saw is that there weren't really many differences. So because I already knew a lot about TBI, we asked about stroke, we asked about epilepsy, encephalitis, anoxic injuries, among others. And you can see, 3 was moderate problems, and 4 was, significant problems, and 5 was very significant. So across all of these conditions, there are fairly significant problems with concentration, with planning. Memory, you get a little bit more variability, but still they're all above 3.5, and concerns in school as well. And then when we look at more of the emotion focused or emotion regulation issues, you see a little bit more variability, but still high levels of difficulty with initiation, getting started with things, anger management, anxiety, a little bit more variable, depression, and irritability. So what we see across diagnoses is that there are fairly common problems that are prevalent. We know that neurocognitive problems contribute to family distress and burden and parent-child conflict. So way back in 1990, Gary Taylor, Denny Droder, and I developed the Family Burden of Injury interview to understand the impact of TBI on families. And we identified challenges with changes in the child's behavior. So obviously, with acquired brain injuries, if you suddenly have somebody who's got more emotional lability, more problems with attending or initiating, that's stressful for the family. But there were other stresses about how other people were reacting and telling them how to manage the child's behavior, the time demands, there were marital conflicts, and there were also concerns about how siblings were impacted. So it was clear that it was a family level problem. So in terms of the impact on the family, and I've contributed to this literature as other people, as we said, there's the child's behavior, emotional and cognitive problems, there's role changes. And so suddenly siblings or other people may need to take a more active role in either household management or caring for the individual with the diagnosis. There's substantial financial stress. There's parental distress, and there's often guilt, grief, and post-traumatic stress. So many times parents blame themselves. And I remember interviewing a woman of a child who was injured while playing in the driveway, and he fell back and hit his head, and he ended up having a brain bleed. And his mother's like, I'm never going to get over the guilt. It's my fault. She was actually resting. She had had chemotherapy for breast cancer. Her husband was out in the driveway with the child, but she was still seeing it as her responsibility. And so part of the dynamic in their household was both her guilt, but also anger at her husband, who let the child fall while she was trying to take a break. There's often uncertainty about the child's future. So all of these things lead to impact on the family. So these are things that based on my 30 plus years of experience that I think are important considerations. So I've kind of called them practice guidelines. I'm not sure that they're guidelines, but I think what we know about children with traumatic brain injuries and other neurological conditions is that the treatment needs to be flexible, because the concerns are diverse and they change over time and over development. Based on what I was just saying, I think it's essential that treatment involve families and that treatment recognize the role of the neurological condition. And also for things like brain tumors and epilepsy, how the treatments for the condition itself may be further impacting behavior and school performance and other things. And let me say a minute about why I say that, because I think when these children are seen in the community, what sometimes is part of the neurological damage like initiation deficits, or part of the medication or long-term effects of brain tumor treatment may look like depression. It may look like low motivation. And it's easy to treat the wrong things if you don't have sort of the full understanding of what's going on. And similarly, standard treatments and behavior change techniques may need to be adapted or tailored for the child's condition and level of functioning. So something, and I'm not going to talk about parent-child interaction therapy today, but parent-child interaction therapy is one of the rules is that you're supposed to respond with a consequence within 5 seconds, and you're not supposed to say the child's name. If you have children with neurological conditions, they often are not, and slowed processing speed, they're often not oriented within that 5 seconds. So you need to adapt those standard things for these populations. So now I'm going to talk a little bit about how we landed on family problem solving as a therapy for acquired brain injuries and other neurological conditions. So one of the really nice things about problem solving, and we took a standard problem solving model. So we took Art and Chris Nazu's problem solving model, which came from Art's earlier work with Desiralia, and adapted it for this population because it has the dual effect of facilitating parent and family coping. And we know they're having a lot of stress, but also providing the adolescent with the injury or with the neurological condition with an executive function heuristic for addressing their own challenges. And so many of these conditions are associated with challenges with planning and problem solving. And so we're giving them kind of a step-by-step approach. The other thing about problem solving is that it's very flexible and allows you to address the different kinds of issues facing different kinds of diagnoses and different types of survivors. So our online problem solving program, and I'm going to first describe what we tested in the clinical trials, and then I'm going to describe what we're delivering through the clinical implementation program. So we had a couple of different versions over the years. From online family, added a couple more core sessions. And then we had supplemental sessions that in the research trials were up to 4 supplemental sessions. In the research trials, we had an initial in-person meeting with a therapist, and then all of the subsequent meetings were like we're meeting now. Back in the early 2000s, video conferencing was pretty primitive. But we did video conferencing way back in 2002, 2003. But each session had 2 components, a self-guided web module and a synchronous session with the therapist. So these are our core sessions. We had a getting started session and then a session on staying positive and handling stress. And so that's really that basic cognitive reframing, what Art Nazu in his work called a positive problem orientation, but really beginning to challenge some of those negative cognitions. And then our third session is where we introduce the steps of problem solving. And we use an ABCDE model. So we have aim, brainstorm, choose, where you evaluate your different choices, do it, and then evaluate. And so beginning with session 3 and then all of the subsequent sessions, families, the adolescent and their family work through that problem solving process around an aim that they want to address. We very intentionally talk about aims and not problems. And that sort of addresses some of the resistance, and oftentimes, particularly with traumatic brain injuries, individuals will say that they don't have problems. And so we say, well, great, you must have aims that you want to work on. And the problem solving is collaborative, so everybody gets a voice in that model. And then we start getting into some of these specific challenges. So getting organized, and we offer some evidence-based approaches, metacognitive strategies, as well as environmental scaffolding to address organizational and other challenges. And then we get into emotion regulation, staying in control, controlling your anger, verbal and nonverbal communication, social behavior and problem solving, so relationships, social skills, sleep, nutrition, exercise. How can you hack your lifestyle to have some cognitive gains there? And then after session 9, we introduced the supplemental sessions before the final session. And these are our supplemental sessions. We continue to develop new supplemental sessions. And so some of these are directed for the adolescent themselves. So after high school, sleep, memory strategies, seizures, initiation, making choices, coping with visible and invisible disabilities, managing your medicine, self-advocacy, pain management. But you'll notice that others are meant for the parents. So there's one on guilt, grief, and caregiving, one for marital communication, one for talking with your teen, and one about the family coping is about how siblings might be affected. So these were kind of designed for to give people an opportunity to have a bit more didactic content and information about these specific areas. So, and by the way, if any of you are interested, either I or Bethany Johnson-Kerner, who's my implementation partner at UCSF, can certainly share the website with you. And if we have time at the end, we might be able to do that as well, but I'm kind of not going to try to do that now. So we did an initial face-to-face trial. So that was just the problem solving, but no computer back in 1999. And then the first online trial began in 2001, and we've done 5 randomized controlled trials of online family problem solving or teen online problem solving. And then we did a comparative effectiveness study, and that was kind of the basis for the PCORI implementation project. So in the comparative effectiveness study, and I'll talk a little bit more about this, we compared modes of delivery. So we looked at face-to-face, no website, what I described to you, which is the website and a therapist via video conferencing, and then just the website alone and no therapist. And so we'll talk a little bit about that. And then we also did an individual participant data meta-analysis where we took all of the data from the 5 prior trials and looked at them together to give us a bit more power. So in the individual participant data meta-analysis, we had 368 children. This was a study just with traumatic brain injuries. Children were between the ages of 5 to 18, and I'll get to that in a minute, and were randomly assigned to online problem solving or an internet resource comparison group. Occasionally we use treatment as usual. To address access issues, everybody got a computer and internet access for the duration of the study. And we assessed outcomes at baseline in 6 months in all studies, and then some studies we had a much longer follow-up. So this is a complicated slide. This was published in the Journal of the International Neuropsych Society, but it shows these are Z-scores controlling for their pre-treatment. So you see all the scores are negative, which means that everybody was better at follow-up than they were pre-treatment on average. But at 6 months, our reddish orange group, which is our treatment group, was significantly better than our control group with kind of small to medium effect sizes. And that was true for both child and family outcomes. Those improvements were maintained at 12 months, but you'll see that our control group improved a little bit. So they weren't significantly different at 12 months post-baseline. But the thing that's really cool about this slide is that at 18 months post-baseline, or a full year after the completion of treatment, we see that the groups separate again, and that our TOPS group is actually, significantly improved and improved from where they were at 6 months post-treatment. So we're seeing emerging improvements over time. And I think that speaks to the consolidation of skills over time. You also see the kind of the close connection between the child and parent outcomes. So they kind of move together, bigger impacts on the child outcomes than on the parent, but not significantly bigger. So as I said, I just described the comparative effectiveness trial a few minutes ago, but this is just a slide showing you this. So this was published in the Journal of Consulting and Clinical Psychology. This is looking at the PEDS-QL over time. And so the bottom line is our face-to-face group. And then our top line is our online self-guided, actually, and the middle dotted line is the therapist guided online. And so you'll see that the face-to-face group did not improve significantly at 6 months, but had improved significantly by the 9-month follow-up, whereas the two online groups had improved significantly at 6 months, with kind of ongoing gains. So the way that Pecori interpreted this was that they're all equally good because everybody's improved at 9 months. The way that I interpreted it is that there are some advantages to having the website. And I think in addition to meeting with a therapist face-to-face, and I think part of what the website offers is videos of real adolescents talking about how they've been affected, and some scripted videos of showing people how to implement skills. And those are things that are hard to get in face-to-face treatments. I think the other thing, and this was all done pre-COVID, is that we know that coming into the hospital to meet face-to-face can be challenging. And this was challenging before COVID. And it continues to be challenging. And that was true. So we stratified randomization. So we only randomized people who were within a 25-mile radius of the hospital to the face-to-face arm. So they were a somewhat different group, but oftentimes it's people who live quite close to the hospital who just have challenges getting there. So it's not necessarily a distance thing that affects access. So we've had quite good feedback and high satisfaction over time, with participants saying that they felt that it really helped them understand their injury, helped them cope with the side effects. The problem-solving process helped because it gave them a new outlook on how to handle things. So now comes the moment of truth. This is Dominic. I have a couple of videos from Dominic, and you can see the Ravens gear here. Dominic was a young man with a traumatic brain injury from Baltimore. And he's going to talk a little bit about how the program helped him manage his anger in this clip. And I think I checked the shared sound, but let me know right away. And if I did not, I'll go out and I'll make sure it's checked. So I'm going to start playing, and if you can't hear it, just give me a shout and we'll start over again.
Like when people, like if somebody just called me out my name or something, most of the times I get angry quick. I mean, if it's my friend or something like that, when they do that, most of the times they be playing. But like people, like grown folks or anybody, when they just cuss at me, I get angry out of nowhere without just saying what they hearing out what they got to say or none of that. So I just be getting angry. I had worked on the little breathing things, the exercising, the relaxing, like it's like the breathing towards me. Miss Andrea had did it. It's like put your arms up, then pull them down, like breathe in, breathe out. Do this. We've worked on a lot of different stuff. I either walk away or I talk to somebody else and tell them how I feel and listen to what they got to say.
So One of the interesting things about Dominic, so first of all, he worked with a speech therapist who was his speech therapist working on language issues before he began the TOPS program. She actually came to his house. So they used the website, but she came to his house because that's what she is. She's a community therapist to address those access issues. And in that video, you heard him recognizing some of his anger issues, which he actually didn't before the program, and kind of, acknowledging, yeah, when people talk to me and when they cuss at me, which probably anybody would get angry if somebody's cussing at you, that he would get upset. But now he has a number of strategies that he learned through the program, including doing some deep breathing, to helping him relax and step back. But he's also using communication skills. So, he's working on inhibition and then talking to people. So I think it's a really nice example of how, people can develop both better awareness, but better self-regulation, and have a toolbox of skills to manage their challenges. So this is Dominic again talking about sleep. And as I said, our final core session is about self-care. So let's just listen to what he has to say.
Normally, I go to sleep around 1, 2 o'clock in the morning. Now I'll be going to sleep at like 9, or taking naps in the middle of the day and stuff like that, turning up my game, my phone and all of that. And I've been getting more rest. And instead of me being like more hype and running around and stuff, I just be chill and calm down and just relax.
So, this is something that I've paid more attention to over the years, because adolescents are chronically sleep deprived. And now we have, you listen, I used to go to sleep at 1 or 2 in the morning, and now I go to sleep at 9. So of course he's got better cognition. Of course he's got better attention and self-regulation, because he's not exhausted. So I think some of those things are equally important. So we've also, one of the things that we did through the PCORI Implementation Award was to expand to other diagnoses. And I wanted to share some feedback from a parent of a brain tumor survivor. And she actually joined our advisory board because she was so excited about it. She said, I think it hit upon many of the topics that both I myself and other parents we've met of children with brain tumors struggle with. Our good friends have complained of their teens struggling with things such as personal space and making friends, as well as headaches and fatigue. But I don't think anyone has helped them connect these things to the tumor. And they've certainly not been given such great strategies for dealing with these challenges. And, that kind of goes back, I think, her quote, and I think she's a writer, so she wrote this herself. She's obviously very articulate, but it goes back to what I was saying before about helping people connect the dots and understand some of the neurological underpinnings of what they're experiencing behaviorally, and then giving them some skills to deal with this. So there was an evidence-based systematic review that was published a couple years ago based on publications from 2006 to 2017. And from that review, they generated guidelines for treatments for cognitive rehabilitation, emotional and family treatment for acquired brain injuries. And as you could hear, we've done a lot of work. So the online family problem solving and teen online problem solving was identified as, one of the only practice standards for emotion and behavior regulation, executive functioning, and caregiver and family functioning. So I want to spend a few minutes talking about who benefits, because I think this is often the question. And in this talk, I've cut out a lot of the research evidence. I I don't have a good count of how many papers we've published, but again, if you reach out to me and you'd like to see more of the literature backing it up, I'm certainly happy to share this. So what we know from our data is that it's good for adolescents. It's not so good for younger children, which is why we've moved to TOPS. And I did not share that slide, but we published in Pediatrics in 2018 in that individual participant data meta-analysis, sort of the differences in people who were younger versus older. And we saw significant improvements in the older adolescents, so sort of 12, 13 and older, but we did not see those improvements in the younger children. And so I would not recommend using it certainly for anybody like under 11. But we do know that it works with adolescents with externalizing problems. So I think that's, some of the comments, because there's a lot of didactic and we're helping people connect the dots. They're like, oh, it's only going to be for those like really smart, high SES families. And that's not the case. It was significantly better with externalizing problems. It was significantly more effective in families with lower levels of education and lower SES, and that was especially true for caregiver depression and distress. And children with lower IQs had more improvements in social competence. On the flip side, we have not seen differences in improvement based on race, ethnicity, or urban-rural status. However, and this is sort of a caveat, a lot of our data were collected in Ohio, and Ohio is not nearly as diverse as you are in San Francisco. And I've loved when I do trainings with your group, because you've got such a rich representation from lots of different groups. And so I'm really interested to see, as we have more Asian Americans and other groups sort of extending our evidence base and understanding. So as part of our widespread implementation, we started with 10 sites and then moved on to 15. And so UCSF was part of our second group of sites. And we're using the RE-AIM framework. So we're looking at reach, how many patients are we able to deliver the program to, efficacy, can we maintain efficacy as we deliver it clinically, adoption, how do sites take it up, how many therapists do we train, are we able to maintain implementation fidelity over time? And then once we kind of take away the supports and we're not there yet, is it maintained at various sites, and what predicts maintenance? So these are our current sites. And as you can see, we have a couple on the West Coast. We have U and Seattle Children's, and then we've got sort of our mountain sites, St. Luke's in Boise, Idaho, Primary Children's in Salt Lake City, and Children's of Colorado in Denver. We have 3 sites in Texas, Dell in Austin, and Texas Children's and Tier Memorial Hermann in Houston. We've got my site, Cincinnati Children's, and nationwide in Columbus, Ohio. We've got Michigan Medicine, University of Pittsburgh Medical Center, CHOP and Kennedy Krieger in the East. And then we have one international site, Holland Bloorview in Toronto. So we have been very successful in training therapists. So as one metric of therapist adoption, we originally, our goal was training 5 therapists per site. So that would be 75 therapists, but at this point we've trained more than 330 people. And we recently had a number of trainees from the BEST program in our most recent training. So Bethany, I don't know whether you can unmute or just type into the chat what BEST stands for, because I don't remember. It's the
Braddock Emotional Support Team, which is philanthropically funded by the Braddock family to support oncology patients, particularly in Oakland, through the foundation.
And they have used it, I think, with some sickle cell patients who have had neurological impairment due to strokes, and I think maybe one brain tumor survivor, but we had a number from there. We've also trained people in other countries and have an Italian version right now, and did not list the UK there. We've worked to expand to different populations. A lot of my colleagues who are most interested in this are neuropsychologists, but obviously there aren't enough neuropsychologists to go around even to do assessment, let alone to do treatment. And so some ways we can extend the program is obviously by offering it as self-guided, but also by involving speech language therapists and clinical social workers to provide support for that. So we do have a therapist training website that has a lot of that information, and we've developed some special topic webinars and that sort of thing. It's not functional now as sort of a standalone training, but it is there. So I'm just going to mention this a little bit because as somebody who's done research my whole career, and I'm suddenly doing clinical implementation, I had a plan for what we were going to do. And as soon as we started doing it, it fell apart. So I haven't encountered any wicked witches, but I've encountered some other things in this journey. And one of the things we did early on was talk to people who were referring patients and really determining, whether some people, so our broad criteria were 13 to 19 years of age. But, immediately people said, well, I've got a patient who's 12 and I think they would do well. Or somebody said, I've got somebody who's 20. And so we kind of talked about some of those things and then expanding to other neurological conditions. And I started with that because I think, we all kind of get into our little silos and, I treat this or I treat that, but there are so many shared neurocognitive challenges that it really did make sense to kind of expand first to other acquired brain injuries and then to other neurological conditions with sort of similar neurocognitive profiles. The other thing was that in our sort of agreement with PCORI, we said that families could choose what treatment we want. So I don't know how many of you are delivering care there, but family choice is really limited in most of our sites. And so some places we found that state of residence. So I am in southwestern Ohio. We have a tri-state region. And except when COVID waivers were in place, it's very hard for people with Medicaid in Kentucky, which is right across the river, or Indiana, which is right down the Ohio River, to get care here, particularly via telehealth. They can come to the hospital, but they're not able to get telehealth. The availability of therapists has been a big challenge, which is why the self-guided arm is a helpful resource. And so we started exploring what hybrid models might look like. And so again, when you're doing research, you want to keep everything cut and dried. And so my face-to-face group in the comparative effectiveness study, I didn't give them access to the website because I wanted it to be just a face-to-face, but they did have a family workbook and they could get handouts, but they couldn't watch the videos. And so now, we've looked at some hybrid models where maybe you start with a therapist and then you work independently and then you come back in and check in with a therapist. And that's worked well for people in Montana, for example, some of whom are seen in Denver, some of them who are seen in Salt Lake City. But again, they can't get telehealth. They have to actually drive in. And so having those intermittent visits has been helpful. We've expanded to a number of new diagnoses, and this is not, this is not all of them. I think what I've tried to stay away from is ADHD and autism and some of the conditions where there's lots of content here that's appropriate for ADHD and for autism, ASD, but they also have their own treatments. And, I think so this has really been for those conditions and diagnoses where there's really less out there, and this can be a useful evidence-based approach. So as I said, we've introduced SLPs. This is just a comment from an SLP. So in terms of our reach, to date, I think since I made this slide last week, I think we're up to 415, Bethany, so it's good, we're going up. It's much lower than we were hoping. And, these are low incidence conditions. And so, and as we move forward, it's kind of broken down pretty evenly between self-guided and therapist-guided, and between TBI and other diagnoses. So, so now I'm going to talk a little bit about TOPS at UCSF and how and who to refer, and then we can kind of have some discussion. So Bethany Johnson-Kerner, who's here, she reached out to me, and that was great because she was looking for ways to, you know what, Bethany, I'm going to just let you tell it.
Sure. So I'm a general child neurologist at UCSF, but I was particularly interested in brain injury, brain recovery, and was really impressed with when I was looking at the national landscape. There were a lot of programs with multidisciplinary clinics, access to clinicians, therapists, recovery resources. And I just felt in general, California didn't have a lot of resources. So the first thing we did was just get out and start seeing the patients, see what they needed. So we established a TBI clinic in January of 2021. So we've had lots of referrals to date. And as we've gone along, just like Shari has tried to emphasize, trying to make it family-centered. So figuring out what families need. And this is certainly one of them that TOPS is filling this need as far as sort of metacognitive training skills, communication practice between parent and child. So when I heard about this program through another child neurologist at Cincinnati, I jumped on the opportunity for UCSF to become an implementation site. So that's how we got connected.
Thanks, Bethany. I know you do a better job of describing it than me. So who can use TOPS? As I said, I think we're always open to kind of discussing whether a patient is appropriate. So age 13 to 19, plus or minus a couple of years. We have been using it with some young adults who are still living at home. CNS conditions, and Bethany excludes concussion here, and I think that's important. One of the big messages of the program is kind of understanding and living with sort of longer term consequences of your brain condition and equipping you with lots of good skills for doing that. And that's one of the reasons that we exclude concussion, because the expectation with concussion is still pretty much for, and I know that there are these cases where people have post-concussive symptoms for a long time, but the expectation is that you should recover and you should recover fully. So this is kind of taking, a different approach, which is why we're not including concussion. But a number of other conditions. We want this to be family-centered. So we want an adult who can participate with the adolescent, and we want the adolescent to be able to actively participate. So they need to be able to focus for 20 minutes. We do have a Spanish language version, and you can toggle back and forth between English and Spanish, so they can speak Spanish or English. We do not have it, well, there is an Italian version, but there's not a lot of Italians in the US, so that's not going to help us. So those are kind of the broad requirements. And again, sometimes, just recently we decided to use it with somebody who had long-term effects from fetal alcohol syndrome, which again is a, CNS neurodevelopmental condition. So Bethany came up with this nice clinical pathway for clinicians at UCSF. So, first of all, you need a teen 13 to 19 with functional difficulties and a known neurodiagnosis. And then they need to be English or Spanish speaking. They need to have an adult who's able to partner with them on the program. They're able to, it says worksheet, but they're able to work on the program with an adult. And we do exclude people with significant psychiatric conditions, especially pre-morbid psychiatric conditions. And so, if their brain insult is because of a serious suicide attempt, or if they had hospitalizations for self-injurious behavior, they would be excluded. And then you can reach out to the brain recovery email or call this number directly. So that's the referral pathway at UCSF. This is what patients experience. So we kind of talked about this before. We do have a paper family workbook, so we can give that to people. We recently had a family who wanted to do self-guided with just the paper workbook. So it's a comprehensive workbook. It's about 50 pages, but obviously you lose some of the interactivity. We consider a treatment completer to have done 5 sessions, and that's about 4 hours if you're working with a therapist, less time if you're just doing them independently. Bethany has worked to establish some opportunities for this third option, which is a provider check-in or an accountability partner. And again, Bethany, maybe you can describe sort of who you've partnered with and what that looks like.
Sure. Yeah, I've done some connections with school psychologists through IEP meetings and other things to connect with teachers, as well as California Children's Services, CCS, which explicitly does not provide cognitive rehabilitation services. But they do have a lot of occupational and physical therapists in their ranks who really appreciate how much cognitive changes after acquired brain injury impact their therapeutic treatment plans. And so we've done outreach to some local CCS MTUs to get therapists connected. So, and I'll share this at the end with Shari's permission, but a community provider link so that anyone out in the community could sign up an appropriate patient with the link and just like Shari said, be an accountability partner.
Thanks, Bethany. So these are just UCSF metrics to date. So 30 patients, 13 with TBI, 17 with other diagnoses, and 3 Spanish speaking. So one mom said it gave us the tools to solve problems we were having and made us feel less isolated. So with that, I'm just going to go ahead and stop sharing and open it up to questions, because as usual, I've gone a little bit long. And it looks like there were some questions in the chat.
I tried to answer a few things as we went along, but Barbara and Shari, please let me go.
Thanks, Bethany and Shari. I'm looking, there was one question that was yet to be, did families, this is Maria, do you want to ask your question? Go ahead, unmute yourself.
Sure. Thank you, Barbara. I think this is fabulous. And I was thinking of it from the point of continued access to care, especially once they've completed the program or once maybe that relationship with a therapist is facilitating services ends. And so I was curious to know if families in follow-up continue to have access to the videos or the games and things like that.
So they do. I have to say, in my experience, people have not accessed it a lot when it's done. And it's one of the reasons why we created the old school paper workbook. That was a request from a parent, and they said, sometimes I want to be able to find something. And, the website's searchable, but it can be so challenging sometimes, right, to go back and find something in a website. So that was kind of the idea of the very old school paper workbook, is that you could go back and find it. But yeah, they could, they don't. Other questions?
Well, I have a comment. Thank you. This is a fabulous talk, and I learned a lot. I do have a question. So I appreciate your mentioning that there are other treatments, other evidence-based approaches for working with children who have, say, an ADHD diagnosis on some of the organizational needs. And I'm wondering if how much overlap. I mean, you know, you started with your talk, indicating that there's a lot of comorbidity, right? And so I'm wondering, how do you any advice for how to work on that comorbidity, right? How is there a sequence that you recommend that works best depending on the critical needs of a particular kiddo?
Yeah, I mean, I think that's a really good question. And, you know, anecdotally, I have some thoughts to share. I mean, we don't have a lot of or any data to speak of. So I think, you know, when we have people like Dominic, who had been working with Andrea Scherer, his speech therapist, for a while, when she introduced the program. So they had already been working on more traditional SLP kinds of things. And then she introduced this, and she thought he was at a place where he was ready for it, both developmentally, because he was only 11 when he was injured, and he was about 13 and a half or so when he participated, but also in terms of readiness to kind of think about some of these things and kind of deal with them. You know, I think for things like PTSD and, you know, TBI or brain tumor, you know, again, you know, we don't have any good evidence. I think because we teach some cognitive reframing and relaxation and other things, there are things, there's lots of other evidence-based strategies in there for families. And so, you know, I think if you look at other programs, there's a lot of overlap. So it's not, I think what we're not is something like CogMed or, you know, a drill-based program. So that would be really distinct from this. I think what's nice about this, at least from my perspective, is it gets the parent and the adolescent on the same page. And so they're both developing this new and shared understanding, but we're also asking the parents to adopt these skills as well. So it's not the case like, okay, you're damaged and you need to do these skills, but hey, we want parents to be using the problem solving. We want parents to be using some of the, you know, stop and think, and then, you know, develop your aim and brainstorm and choose. And you know, we have seen improvements in parental problem solving and parental distress. So it's kind of working on multiple tracks. And that was another slide that I took out. But I think by involving both, then you've got sort of those two pathways for change and not just putting it all on the adolescent themselves.
Thank you for that. Dr. NJ Lin, you have a question? You'd like to unmute and ask it?
Oh, hi, hello.
Hi.
I'm Angie. Great talk, by the way. It's so exciting to see all the work. And my question was, if somebody has ASD, but who's very verbal and cognitively intact, and they did have some kind of neurological condition, like I met a boy who actually had meningitis and some other kinds of, I think, brain medical condition that arose, and he's had some residual effects from that. Would somebody like him be eligible? It's not to treat the ASD, but the
Sure. Yeah, no, I think they would be. And let me just say, because I don't want this to become, I mean, maybe it will become all things to all people, but one of the colleagues who's worked with me on the website has a child with ASD, and he's actually used a lot of the program with his own child. And he's like, oh, it works really well, Shari. And I'm like, yeah, but we're not going down that path. But I think that the person that you described, who's had, you know, a brain insult from the meningitis, but
Mhm.
also has ASD would be very appropriate. And we had those people in our clinical trials, but we didn't. So it was not an exclusionary criteria as long as they could, you know, communicate and participate and meet those other criteria. But what I've been trying to avoid is just ASD. And like I said, that's a different, I think we need to do a different study. So yeah.
Yeah, I guess if the primary concern is from some kind of neurological insult. Yeah. Okay, thank you.
So I think we're about out of time. Any final questions? Please feel free to reach out to me or Bethany with additional questions. And if you have students who would like to be trained, or if you would like to be trained, we don't have any trainings on the books now, but we'll probably do one in early 2023. And if you have a quorum of people, you know, I'm always happy to have more people trained as well. So
appreciate your time, Dr. Wade. It was really wonderful. And thank you for everyone else who attended, and for the wonderful discussion. And yeah, everyone be well, stay healthy, stay dry and cool. Take care.
all right, thanks everyone. Bye.
Bye.